I'm sure we'll still have a few more people trickle in after, but that's okay. All right, well, good afternoon, everyone, and welcome back to the Brainy Boomer Lecture Series. I'm so very happy that you've all joined us today. We would like to begin by acknowledging that the McGill University Research Center for Studies in Aging is located and our work is done on unceded Indigenous lands. The Ganyankahaga Nation is recognized as the custodians of the lands and waters on which we gather today. Tiohtià:ke, commonly known as Montreal, is historically known as a gathering place for many Indigenous peoples. Today, it is home to a diverse population of Indigenous and other peoples. We respect within the community, we respect the continued connection with the past, present, and future, and our ongoing relationships with Indigenous and other peoples that we serve within the Montreal community. In 2007, the McGill University Research Center for Studies in Aging, or the MCSAge Education Committee, started the Brainy Boomer Lecture Series in order to suggest practical steps to both improve and maintain brain health, as well as to promote healthy lifestyle choices amongst the most populous generation in history. The MCSAge Education Committee, which was founded in 1996, has three main objectives: identifying education needs of healthcare providers, seniors, caregivers, and the public, and to develop responses to meet some of their needs; to enhance the positive image of the aging process by addressing stereotypes and myths about aging; and finally, the dissemination of research on aging. Dr. Catherine Ferrier is a family physician and holds a certificate of special competence in care of the elderly from the College of Family Physicians of Canada. She works in the Division of Geriatric Medicine of the McGill University Health Center, where her focus is on cognitive disorders and assessment of decision-making capacity. She is an assistant professor in the Department of Family Medicine at McGill University. Before continuing, we would like to remind you to please mute yourself on Zoom, and that if you have any questions, you could either write them down in the chat box or you could wait until the end of the conference to ask them yourself. And now I'd like to invite Dr. Ferrier to start her presentation.
Thank you very much. Thank you for inviting me. Is the volume okay?
Yep, you're good.
Perfect. So I'm going to speak about decision-making capacity, what it is, how we assess it, and how to plan in case it is lost. This is a brief outline of what I'm going to be talking about today. So decision-making capacity and its assessment, medical decision-making in the context of possible incapacity, and planning ahead. So this is a patient that I saw in the clinic last year. Very brief outline. So an 88-year-old woman referred for cognitive difficulties, possible Alzheimer's dementia, vitamin B12 deficiency and inadequate nutrition, not able to care for her home, take her medications, nourish herself properly, refusing services, not managing financial and other business, needed help from her sister, risk of abuse, Mini-Mental, which you're probably familiar with. It's a 30-point scale that we use to assess cognition. And more importantly, the last two summarize like at least 1 hour assessment, but she's not aware of her cognitive losses. She denies all the concerns, she rationalizes all the concerns. And because of that, because she could not, address the problems that she had, we found her incapable of making personal decisions and managing her assets, which are two different areas of decision-making. We'll come back to this case at the end of this little part. So decision-making capacity is a person's ability to make and act on his or her own decisions. That is very brief summary of what we're looking for. So medical conditions that could lead to losing decision-making capacity, it could be from birth, developmental disability, could be dementias, advanced neurocognitive disorders, not necessarily early dementia, but later on. Some psychiatric conditions, brain injury, stroke, acute illness, which may be temporary loss of capacity, or advanced terminal illness. So beware of common assumptions, and I see this in my practice all the time. So just because somebody has a diagnosis doesn't mean they're necessarily unable to make decisions. It depends on the severity. Just because we find somebody's decisions unreasonable doesn't mean that they're incapable of making decisions. That happens with healthy people all the time, that we don't agree with each other's decisions. Capacity is not a person's ability to live alone and care for themselves and their home. So we saw this person just now who was not able, but that's not what led us to find her incapable, but was her ability to reason through and solve problems that was the issue, and not just the neglect. People have different standards for care of themselves in their home. Doesn't automatically mean that they're incapable. And a score on a cognitive test, although it is one piece of data that helps us, it does not determine capacity or incapacity. So when do we assess capacity? So the reason I put this question up is that just because somebody has a certain diagnosis, like Alzheimer's disease, for example, doesn't mean we necessarily assess capacity. We only do it if there's a reason to do so. So in the Quebec law, for example, it says that we assess if there's both suspected incapacity due to a diagnosed medical condition and a need for protection. So for example, somebody who has progressive neurocognitive disorder could have family members that are close to them who pitch in, ensure that they're safe and cared for, ensure that their finances are looked after, and you never need to put into place any more onerous legal way of decision making because the informal situation is working. So both incapacity and a need for protection. And generally, at least in my field, which is dementia and long-term incapacity, so only if there's a plan to put into place either homologated mandate, all of these things we'll talk about later, or put into place tutorship or curatorship if they're found incapable. And stepping back from that, for example, if somebody is perhaps temporarily incapable or thought to be, they're in the hospital and an important decision needs to be made about medical care, for example, then there might be task-specific assessment of capacity to ensure that they're able to make the decision that they are faced with. I think so. This is what the Public Curator's website says about the need for protection, which I just mentioned. Basically, as I said, it doesn't always mean that legal protective supervision will be instituted. That is very onerous and people lose their rights. We only do that if we absolutely have to. And so the need for protection exists perhaps because of their isolation, the duration of the incapacity, or many, many other social factors that lead to them needing protection. So the criteria, so this is what we're looking for when we assess decision-making capacity in a patient. Can they understand the information relevant to making the decision? Can they appreciate how that information applies to their own personal situation? Can they reason? So take that relevant information and engage in a logical process of weighing options. We put treatment options because this was about medical care, but it can be any options in life, and express a choice. If you can do all of those four things, you are capable. If you can't, you're incapable. In between, there's a gray zone, and there is, I think by necessity, there will always be a gray zone. And so when we assess, in a sense, we have to determine where the line falls to actually determine that somebody is capable or incapable. And the way we do that in practice is to walk through the decision with the patient and determine to what degree they understand, appreciate, and can reason and express a choice. So the areas of decision-making that we might be looking at, personal decisions include medical and others, such as where to live. Can you live safely at home or not? Do you need to move somewhere else? Do you need to get help? Financial decision-making, and sometimes very targeted capacity. Is this person capable of signing a will, signing a power of attorney, signing a mandate? So getting back to this woman, can she understand, appreciate, reason, and express a choice about her impaired cognition leading to her loss of functional autonomy, which is really what we're dealing with. Since she did not acknowledge her condition, she's already not understanding. She does not know that she has dementia. Therefore, she cannot appreciate the consequences of her dementia and reason through it and put in place measures to keep her safe. And that, again, it's a nutshell of a very complex assessment, but that is why she was found incapable. And so that's what we're always looking for. Can they understand, appreciate, reason, and express a choice? It's a very brief version of the teaching that I give to medical students and residents who are going to be called upon to do this. So who makes medical decisions for an incapable person? So this is according to the Quebec law. If they have a legal representative, so a mandatory, a tutor, or a curator, that is the person. If they don't, then their spouse. If there's no spouse, or if the spouse is not available, or then any close relative or even a friend, anybody who's concerned about the well-being of the patient. Advanced medical directives, which I'll talk about in a few minutes, are a new thing in the Quebec law since 2016. They are binding and overrule decisions made by others on the patient's behalf. I think that's a bit problematic, and we'll get into that a little bit later. Okay, so medical decision-making. This is a case, not mine, but taken from the Canadian Medical Association Journal, a blog a couple of years ago, written by a resident about her grandmother. So she was 88, cognitively intact, admitted to the hospital for a heart attack, heart failure, worsening kidney disease, and the hospital called her family early in the morning about code status. So should we resuscitate her if her heart stops, which is what code status means. She wanted full code, full treatment, and she was considered capable of deciding. So really there was nothing to ask the family, but it was good to involve them and inform them of what was going on. Then as the admission progressed, she had a pacemaker put in because her rhythm was not safe. She had dialysis because of renal failure. She had many, many complications of that illness. And no healthcare provider tried to explore her understanding of her conditions and options after that initial 6 a.m. contact. Palliative care was not consulted, and she died 5 weeks later, shortly after being offered a colonoscopy. Probably you have alarm bells ringing in your mind about what's wrong with this case, and this is very, very common thing to happen in our hospitals. We'll come back to this at the end, and if you want to discuss it in the question period, I would be happy to do so. So informed consent, you're probably aware of. No medical intervention can be carried out on a person without their free and informed consent. So that means it must be voluntary, they must be capable of consenting, and they must have been properly informed. So consent is informed when the patient has received and understands detailed information on all these things, their diagnosis, including any uncertainty about it and other possible diagnoses, the nature and purpose of the proposed investigations or treatments, their chances of success, risk, or harms, available alternatives and what they might do, and the consequences of leaving a condition untreated. You may be thinking that I'm not always told all these things when I consent to medical treatment, and that's probably true, although the bar goes higher and higher as the medical treatment becomes more complex and the risks and benefits are greater and maybe harder to understand. So the notion of limiting medical interventions. So when we're young, we want to try everything that would save our life, basically, for the most part. But it can be good medicine and good ethics to limit treatment when the risks and burdens outweigh the expected benefits. And there are other ways of phrasing this, but I find this very useful, the sense that what we're trying to avoid is treatments that will harm more than they will help. So risks and burdens outweigh benefits. So older people, especially those with dementia and frailty, which I'll explain in a moment, are at higher risk of adverse outcomes of medical interventions. So you take a 30-year-old and put them in the ICU for pneumonia, and chances are they will recover from the pneumonia and get better and go home eventually. You put a frail older person in the ICU, and perhaps they have complications of the ventilation, perhaps their kidneys start shutting down, perhaps their blood pressure drops, many, many other things can happen. It's because they're frail and at higher risk of complications. So the decision to undergo that intensive treatment might be different in that person. So this risk increases progressively over time as we get older and more frail. So the risks and burdens increase and the benefits decrease. So there might come a time when we decide that we do not want that treatment because it's too burdensome or risky. So that's when we integrate a palliative approach into our care. Palliative care traditionally is thought of as for cancer. That was how it started, but a palliative approach can be applied in anybody who has serious illness and might not survive their illness. Even if they might survive their illness, we try to palliate, relieve their symptoms, in addition to cure them, or perhaps even in the place of trying to cure them if it becomes too burdensome and risky to try to do so. And this is not devaluing or abandoning the patient. It's accepting that we can no longer halt the natural course of the illness. And I'm not saying in this phrase that older people are never devalued or abandoned in our healthcare system. Unfortunately, they are sometimes, and that causes me a lot of distress. And that's another story in a sense. But good, reflected decisions to limit or withdraw treatment can be the best care for some people in some circumstances. So frailty, just briefly, in geriatrics, we all refer to it. We don't always agree on how to define it, but it's what makes somebody more vulnerable to poor recovery after a stress, whether the stress is an illness, medical treatment, or whatever, because of cumulative decline in all of the organ systems. So a relatively small event could have a drastic effect. So a treatment that could be beneficial in a younger person or a more robust older person could cause harm to someone who's frail. So the risk-benefit ratio is not going to be quite the same. So how do we plan ahead for all of these things? So advanced care planning, this is how it started out. So ventilators, as we know them, positive pressure ventilation blows air in and out of your lungs and takes the place of your breathing muscles. That was invented in 1952, so 70 years ago. CPR was invented in 1960. So that was really the days when we could actually do things to keep people alive who otherwise would have died. Some of you may remember the Quinlan case in 1975. Karen Ann Quinlan was a young woman who suffered a respiratory arrest and was on a ventilator for a prolonged period of time, and it did not seem likely that she would ever get off the ventilator. So her parents asked the hospital to withdraw it. It turned into a court case, and in the end, the parents won the court case. I just found out when I was researching this that in the interim, she was actually weaned off the ventilator and lived for several years, although she never recovered consciousness. But that was a precedent for withdrawing ventilator support when it seemed to be more burdensome than beneficial. And the first living will was in 1969. So what are the elements of advanced care planning? There are basically three. One is a written directive, one is naming someone to decide for you, and the third actually encompasses the first two. So I'll just explain a little bit in more detail. So a written advance directive or a living will is a list of interventions someone would choose to have or to forego if they're incapable of consenting. This has severe limits, as I will explain. Naming a substitute decision maker, very, very useful, assuming that we have somebody who is able and willing to take on that role. And the third is really the state of the art now for advanced care planning. So a dynamic process of dialogue supporting patients and their families to formulate goals of care as they move along their trajectory of a progressive illness. You can imagine that at the beginning of a severe illness, you might not know how things will turn out and want to try harder to prolong life or to recover than you would later on when it's more and more evident that you're not recovering from this illness. So that's why we need this dynamic process of dialogue. So what are the problems with the written advance directives? I'm not saying they should never be used, but I think it's important to be aware of their limitations. So consent is not informed. So it's not a substitute for informed consent in the sense that if you don't know all of the details about your condition at the moment that it will be implemented, then your consent is not fully informed. Also, they tend to focus on procedures and not outcomes. So what does that mean? It means that you're saying, do I want a ventilator or do I not want a ventilator? But whether you want it or not depends a whole lot on what your medical condition is at the time that it's being contemplated. As a very simple, kind of silly example, if somebody has acute asthma to the point that they're going into respiratory failure, but has otherwise healthy lungs, and you need a ventilator overnight until the asthma improves, that's one thing. That's one end of the spectrum. And if you have chronic pulmonary disease with 4 or 5 admissions in the last 6 months to a year because your lungs keep failing because they're so damaged, that's the other end of the spectrum. And so just saying I do or do not want a ventilator doesn't address that difference. Many of them have ambiguous terminology. Many of them are open to interpretation depending on the person reading it, which is kind of contrary to the purpose. Also, people often can't foresee what they might want in a hypothetical future situation, which I'll get to. And people change their mind. As you go through a disease, your goals of care change. Typically, I'm not talking really about cancer, but I'm sure we've all known people with cancer who, with the initial diagnosis, yes, I want chemo, yes, I want surgery, yes, I want everything. And then as things are tried and maybe give you a remission for a while, and then it's not working anymore. Well, your goals change. You're not trying to get better anymore, but you're trying to have a good life for the time that remains, or whatever. That's what palliation means. So why do I say that we predict poorly our quality of life in hypothetical situations? This has been looked at a lot in the psychology literature, not just about medical decisions, but about many things. So there's something called cognitive biases that distort our thinking. So one is a projection bias, so projecting our current preferences onto a future situation. One is called focalism, so focusing on what gets worse, not what remains positive in life when we're sick. Another is immune neglect, so underestimating our ability to adapt. And so that's why we often see a response shift, which is a change in preferences for care as a person adapts to and accepts advancing illness. So why do I say that advanced consent can't be informed? Well, what we know is the age of the person, their diagnosis, their degree of frailty. We know that. We know what science says about prognosis given this information, more or less. It's never that precise. And we know about the treatments and their kind of overall expected risks and benefits. But what we don't know is what's going to happen to this person in the future, how their medical condition will evolve, how their goals will evolve, and also how exactly the match between benefits and risks at the time that the procedure is being contemplated. And if the person's incapable of decision making, they can't consent to that. And so the advanced consent is lacking in information. So this is from a recent paper by end-of-life experts explaining why lists of procedures on paper are problematic. So they say treatment choices near the end of life are not simple, consistent, logical, linear, or predictable, but are complex, uncertain, emotionally laden, and fluid. Patients' preferences are rarely static. They're influenced by age, physical and cognitive function, culture, family preferences, clinician advice, financial resources, and perceived caregiver burden. So you can see this is a whole lot of stuff, but that's the mix of being human, right? Leading to, in the literature, this was actually quite an old paper, 2004, people saying like living wills don't work. That doesn't mean that living wills have been abandoned. It doesn't mean that they're never useful, but a document of what I want and what I don't want on paper is very, very limited in its effectiveness as far as really ensuring care according to the person's wishes and their condition and their needs when the time comes. So this is what I recommend for written advance directives. If you can, in your directive, number one priority is to name a substitute decision maker. So we'll get to how to choose them, but generally it's somebody in your family that you trust and that you think would be good at that job. If you don't have a family member, it can be a friend. But there could be people who really have no one in their entourage that they would trust as a substitute decision maker. Then perhaps the written directive would be the next best choice. Next point, learn about your state of health and the potential benefits and risks to you of different medical interventions. So before saying I would or would not want X, find out in my condition with my heart disease, lung disease, whatever I have, what would be the benefits and risks and burdens of this procedure to me. And that we can find out by discussing with the health professional who knows about our medical condition. My advice is minimize instructions on specific procedures. One that we do need to think about advance is CPR, as I will show you in a moment, because there's no time to think when the need arises. Mechanical ventilation, maybe we have a little bit more time to think when the need arises. But above all, empower the substitute decision maker to make the final decision in the moment. Give them that authority, having had discussions with that person and shared our values and goals with that person in such a way that they are deciding according to who we are and what we would want. And in my opinion, written instructions should never be binding because it ties the hands of the health professionals and might stop them from doing something which is actually the best thing that you could have. So that being said, there are several tools for written advance directives in Quebec. The first is the Advanced Medical Directive. Second is the mandate. And the third is the levels of care and CPR form. You might be familiar with these tools. So the Advanced Medical Directive became law in 2016. And it's actually quite limited in its scope, which makes it safer than something that's more broad. So for an advanced medical directive to be valid, you have to be in one of the following situations: a serious and incurable illness at the end of life, either a coma or permanently unconscious, or advanced dementia and no chance of recovery. And the treatments that can be requested or refused by advanced directives include CPR, ventilator, dialysis, and artificial nutrition and hydration. So it doesn't involve anything else, and it doesn't involve other situations except at the end of life and incapable of decision making. So it's limited to 4 specific interventions, tightly defined situations. So what are the limitations? I've already told you that I don't think directives should be legally binding. That's my second point. But also because it's impossible to predict all the possible scenarios and treatments that might be indicated, as I've already told you. So legally binding, it doesn't override the competent patient. If you're competent, you decide. But it overrides anybody who might have a better idea of what your wishes and your needs are. We sign documents and then we put them away somewhere in a drawer or in a safety deposit box, and we forget about them. And our wishes can change after signing this document. And I see that as a big problem. We don't spend our whole life thinking about whether our documents are up to date. Even wills and mandates are often not up to date. So to have a binding document that you wrote at a certain moment of your life and that you haven't updated as your wishes change, I find that problematic. Okay, so a protection mandate, this is not just a medical tool, although it does apply to medicine. So this used to be called a mandate in the event of incapacity. A few years, the government changed the name to protection mandate. So it's a document in which we designate one or several people to care for ourselves and our property if we become incapable of doing so ourselves. So to make decisions for us about our well-being and our property if we can't make them ourselves. And that's a very useful tool. I think basically every adult should have a mandate. You never know what's going to happen. You walk out your front door and get hit by a bus or whatever. It's good to know who would decide for you. Although there are means, as we'll see, if you don't have one. But it's a useful thing to have. What I find problematic is that, so the purpose of the mandate is just to name a decision maker. But many notaries now, and I see my patients' mandates, and this is a text that I've seen in many mandates of my patients, which makes it very obvious to me that it was not invented by the patient because it's always the same, that it's something available to notaries that they insert into people's mandates about end-of-life wishes. And so this is what it says: the mandatory shall make all decisions, keep taking into account the following. But I'm opposed to, so you can see that I put certain words in yellow. That means I'm worried about those words. I'm opposed to all heroic diagnostic measures and therapeutic measures that are superfluous given my condition. So what does heroic mean? You ask 10 members of the public, they would probably say different things. You ask 10 doctors, they would say different things. We don't know what heroic means. What is superfluous given my condition? Well, that, in a discussion between a competent person and their family and a health professional, you could probably figure out what is superfluous given your condition. That's what I've been talking about up until now. But is that obvious to the doctor in the emergency room? I don't think so. But in a sense, this opens the door to somebody thinking that somebody's thing is superfluous because they look at you and you're old and you have dementia and they say, I wouldn't want to live like that, so any treatment is superfluous. That's what I find problematic about this, is that it really opens the door to many, many things. The last one, I'm opposed to any treatment that could cause serious after effects or leave me in a vegetative state. That is like totally useless in the sense that almost any procedure can have side effects. Most of the time, they're not serious. Some have serious side effects. We might choose the procedure if the risk of side effects is low, but it's not zero. But if we exclude anything that could ever have serious side effects, well, then we would refuse most medical procedures. And so, on the other end of the spectrum, if it's very, very likely to have serious side effects, well, nobody's going to recommend it to you. So this is like anyway, I think it's like a useless statement. So I think that including medical end-of-life choices in a mandate is not a good idea. Better to discuss them with the people that are going to decide for you. And a verbal conversation always is easier to explain, is easier to exchange and to understand in depth than a few words on paper, especially if you didn't write them. And if you really want to write something down, you could put it in a separate document and give it to your substitute decision maker. That's what I advised my parents to do a number of years ago. And I think that that's a good way to sort of cover all the bases. This is another document called Levels of Care and CPR Decisions. This is used in all healthcare establishments in Quebec and put into the file. This is the pertinent part, which I think this is a useful document, but it has to be used well. So we'll look first at the CPR box, which is near the bottom. You notice it says attempt CPR or do not attempt CPR. The attempt is an important word because CPR is often not successful. So saying to somebody, would you like us to restart your heart if it stops, is a ridiculous question because often we don't succeed in restarting their heart. So attempt or do not attempt is important. And I think that's an important thing to decide based on our medical condition. Again, if we're 25 years old, we would probably put attempt. If we are 60 and healthy, we might also put attempt. But if we're 85 and have dementia and heart disease and a few other things, well, then the chance of it helping us gets lower and lower. And so that's a reasonable thing to consider ahead of time. The levels of care you see here, A, B, C, D. So A is prolonged life with all necessary care, as we would for somebody who has no health limitations generally. B, prolonged life with some limitations. C, ensure comfort as a priority over prolonging life. And D, ensure comfort without prolonging life. So people understand this in different ways. I always err on the side of caution. I don't know who will be the health professional receiving my patient when they arrive in the emergency room and how they will understand the needs of the patient that they've never met before and is perhaps alone and confused from their illness or has dementia. So older people who perhaps would not want CPR or ventilation, I generally advise them to choose B with a substitute decision maker so that the substitute decision maker who knows all of the current information about their health state can decide which limitations would be appropriate for that person. So it's not everything, but almost everything, and to be decided in the moment based on current knowledge of the person's condition. C and D, to my mind, are when death is imminent, when you have a terminal illness and we're approaching death. So then you might not treat something reversible. You might not, for example, transfer to the emergency room if that's going to be very stressful to the patient, which it is for somebody, for example, with advanced dementia because of all of the noise and lights and confusion, and they get more confused than they were already, and they're on a stretcher and they can get tied down and many terrible things that happen in the emergency room. So emergency rooms are great, but they're not always what's indicated if you're approaching the end of life. And what you need is to have your comfort addressed as opposed to prolonging your life at that time, which is not possible anyway. So these forms, if you're admitted to a hospital, often if you're admitted to CHSLD or other residents, you'll be asked to complete these. It's important to educate yourself before completing it, and to talk with other people, health professional and family member, before completing it. So I was talking about effectiveness of CPR. This is from a medical website that we use. It's like an online textbook that's updated all the time. That's why it's called Up to Date. So this is the outcome of sudden cardiac arrest. So your heart stops. If nobody does anything, you will die. So if you're out of hospital, like you're walking down the street, but 1/3 are successful initially, but other people die in the interim, and about 10% eventually will be hospitalized and discharged from the hospital. So that means 90% will die either immediately or later on. And if you, there's some noise there, I don't know what that is, but maybe somebody has their microphone on. So as you get older, and if you have one or more chronic illnesses, then the success rate keeps going down. In hospital arrest, so you're in the hospital and your heart stops. Obviously, you get help faster, and all of the technology is there. So the rate of, but still, the survival to hospital discharge. The reason there's a range is because there's different studies that have different percentages, but somewhere between 6 and 19% survival to hospital discharge. And keeping in mind that you may not be exactly as you were before, may have neurological damage, and in the interim, but this is CPR. 40-year-old man who has unknown heart disease and suddenly arrests while he's jogging. And that's very different from somebody whose organ systems have been declining over many, many years. So what's the gold standard for advanced care planning? This is what's advised in most advanced care planning programs now. So reflection and communication over time of life and healthcare goals. This sounds soft, and it is soft, but it includes all of the hard information. So that should be ongoing throughout the illness, includes naming a decision maker, empowering them to make decisions based on their knowledge of the person's goals, medical conditions, degree of frailty, and advice from the healthcare team. And on the other hand, educating health professionals to conduct what we call serious illness conversations. I'm sure I won't surprise anyone if I tell you that health professionals are not always good at doing this. So that's another aspect of the evolving science, is to make sure that doctors and other people in healthcare are actually able to give the information in a way that facilitates informed decision-making, taking into account the diagnosis, expected prognosis, and degree of frailty. So how do we choose a substitute decision maker? These are just a few points. Do I trust this person? Do they have the skills to communicate effectively with my care team, or are they too shy or too bossy, or whatever? Can they act under stress? And would they be available? Do they live here, not in Australia? Whatever. So what is goal-concordant care? This is a term that's used more recently. So to have care in accord with our goals. That sounds wonderful, and that's what we all want. And so that's why this is not a simple, straightforward process, but requires a lot of discussion about goals. And so as we've seen, goals evolve over time as our health status changes. So that's why we can express a specific wish about a specific treatment and expect it to apply for the rest of our life. That's why it's important to be aware of people's needs over time, whether it's their medical condition, their risks of intervention, also what gives them comfort, what distresses them. I've had patients who are terrified of medical interventions and others who wanted to try everything. Everyone's different. And that's why it's important to have somebody who can speak for the patient if they can't speak for themselves. So this is one program that's been developed in Canada called advancedcareplanning.ca. You can look up the website. I find it quite good, and it follows this approach. So here we have the 5 steps of advanced care planning according to this program. So think about what's most important to you, your values, wishes, and beliefs. Learn about your medical, about your overall health. Sorry, I can't read this. I need new glasses. This may include your current conditions and what might change about your current condition. Decide about who you would wish to decide for you. Talk about your values, beliefs, wishes, medical conditions with your substitute decision maker, family, friends, and your doctor, other health care providers, and record them as you wish, not necessarily recording specific instructions, but you can do that if you want, but above all, recording your values and what is important to you and how you would want to be treated if you were in a healthcare situation. This is the workbook that's on that website. It goes through a whole many pages of questions to guide you through that reflection process. This is another similar program in the US called the Conversation Project, helping people share their wishes for care through the end of life. You can look up both of these and see if you like any of them. I think both of them are quite good. This is health professional education, so how to speak with a patient about a serious illness. And as I mentioned, we all need to learn this. So it's a guide to the conversation. Set it up. What are we talking about? Assess the understanding and preferences of your patient. Share prognosis. So explain to them about their illness, what to expect from their illness. Let them ask questions. Explore topics such as goals, fears, sources of strength, support, and then go on to try to determine what are that person's goals of care to be able to help them to make an adequate decision when the time comes. So what are obstacles to these conversations? So on the patient and family side, well, some people don't want to have this kind of conversation, or maybe they're too sick. Maybe they never thought of it before. Maybe they have documents, but they're ambiguous. Or maybe the substitute decision maker is not around or doesn't want to collaborate or doesn't understand or whatever. That means that the planning was not done adequately. So what about the professional side? Lack of time. Doctors are always in a hurry. Afraid of causing anxiety to the patient or the family. That is real. Waiting till a moment of crisis when it's too late. Only having the conversation if you think that they should be refusing something. It's like CPR. Quality of the conversation, ensuring that you're talking about things in a way that the patient and the family understands. And perhaps the professional lacking knowledge or information that's necessary for the patient to make that kind of decision. So this is the case I showed you earlier. So you can see many, many lacks in this case. It doesn't say so explicitly, but it would seem that this woman, before going into the hospital at 88 with her heart attack, had perhaps not reflected on any of these questions before. So she was faced cold with a code status question when she was acutely ill in the emergency room surrounded by strangers, having probably not slept that night. So that's certainly not ideal. But then that can happen. It happens to a lot of people. Not everybody plans, as I'm trying to help you to do. But on the side of the professionals, having, okay, so the first night she said, if my heart stops, I want you to restart it. As soon as that patient is a tiny bit stable and has had some sleep and the family can come in, that's the time to really look at what is her condition now, what's happening to her heart and her kidneys, what is the likelihood of them recovering, and so instead of saying just the benefits and risks of a pacemaker, the benefits and risks of dialysis, we have to look at each of those things in the context of the whole picture of this person's health. And she died after 5 weeks of acute treatment that was still had a curative goal when it probably could have been obvious to someone that she was terminally ill, and she never had that chance to have the peaceful end that, for example, palliative care offers, and that could be offered in a regular hospital bed if people adjust their approach to the reality of somebody's condition, at least to the best of their ability. You can't always predict the future, but you can have these ongoing discussions, which should be a part of medical care in anybody who's at risk of dying.